Hi, this is Michael Altos, and today we're talking about the coagulation system, and this is part 1. First, an overview of coagulation, and this is probably the shortest, quickest overview of coagulation you'll ever have. Coagulation has two parts. There's primary hemostasis and secondary. Primary hemostasis really involves platelets. Platelets need to adhere to the site of bleeding. They need to be activated, stabilized, and they can also be inhibited, and this is part of the checks and balances that we see throughout our discussion of coagulation. Then there's secondary hemostasis, which brings in the clotting factors to create a thrombin plug. The clotting factors are activated. Usually some sort of injury leads to activation of tissue factor, which in turn activates factors 7, 10, 5, and then 2. Together they form a complex which leads to the amplification step, which we call the thrombin burst. Once thrombin is released, that's factor 2, it activates more platelets, as well as further activates factor 5, and then factors 8, 9, and 11. Propagation is the step where fibrin crosslinks are created in order to stabilize platelets and create a stable fibrin plug. And finally, inhibition is part of the built-in checks and balances. And this reminds us that clotting is a constant process that is occurring and reversing every moment in your body, throughout the body. At every step, there's clotting and clot breakdown that happens. Fibrinolysis is the process of breaking down clot, and this occurs when plasminogen is activated into plasmin, and plasmin is the substance that degrades fibrin. I'm sure you don't have any questions about that because it was so comprehensive, but if you do, please drop me a note. The first substance we're going to talk about is heparin, and specifically unfractionated heparin is what we are referring to when we talk about heparin. Heparin works by binding to antithrombin 3, which is a natural anticoagulant, and heparin activates it. This is important to remember. Antithrombin 3, in turn, inactivates many other coagulation factors. Now, it's important to note that paradoxically, there may be patients who don't respond to heparin, and the treatment is sometimes to give them FFP. Now, this sounds counterintuitive since FFP is usually what we give people to help them clot. But in fact, if a patient has a deficiency of antithrombin 3, and you can have an acquired antithrombin deficiency in cases of DIC or sepsis, acute thrombosis, liver and renal disease, patients who are on ECMO or hemodialysis, or even just surgery and trauma. So in that case, FFP will replenish the antithrombin 3, and in turn, that will allow heparin to have action once again. Heparin is dosed in units, and a unit of heparin is defined as the amount of heparin that will prevent 1 milliliter of citrated blood, usually sheep or cat blood, from clotting for 1 hour. Heparin can be given intravenously or subcutaneously, usually not intramuscularly because of the risk of hematoma. And heparin, because it is large and it's charged, does not cross the placenta. Heparin has some unusual dosing because of its nonlinear dose-response relationships. A lot of this has to do with its extensive protein binding, and its elimination half-life changes based on the dose, but usually it's in the area of 1 to 2 hours. For this reason, heparin is usually used only in the inpatient setting. Heparin levels are hard to measure, and classically we've measured heparin activity. This was first done by measuring the PTT and attempting to maintain it at a level of about 1.5 to 2.5 times the patient's baseline. Nowadays, we've moved away from this, and most patients who are on heparin are monitored with an anti-factor 10A assay, which is a heparin activity assay. Another test that can measure heparin activity is the ACT, the activated coagulation time. This is an easy test to use and it's very reliable for heparin. The way it's done is blood is mixed with an activation substance and the time is measured in seconds until a clot is formed. The ACT should be measured about 3 minutes after heparin is given, and it should be compared with an ACT that was drawn and measured as a baseline prior to giving heparin. You may be giving heparin and measuring ACTs in the operating room. Usually for a vascular procedure, the surgeon will want the ACT to be about double the baseline value. So if a typical bolus of heparin is around 5,000 units IV, and a baseline ACT will be somewhere in the 100 to 150 second range, so we'll be looking for a double that baseline, so something in the 300 range. Patients who are going on cardiopulmonary bypass will want a much higher ACT, usually at least 300 to 480 seconds. And for these patients, the heparin bolus is often around 300 to 350 units per kilogram. So we're talking about 20,000 to 30,000 IV units of heparin. Heparin is used for a number of different indications. It's used to prevent and treat clots, or thrombus, and thromboembolism. So this would include DVTs, pulmonary embolus, mural thrombus, and even acute myocardial infarction. Patients who are on extracorporeal devices like ECMO, cardiopulmonary bypass, or hemodialysis will definitely have heparin used to prevent clotting inside of these machines. Heparin is also given routinely to inpatients to prevent DVTs. Usually the dose is 5,000 units subcutaneously every 8 to 12 hours, sometimes increased to 7,500 units for patients who are very obese. Like I said, this is used in many hospitalized patients, especially surgical patients, and certain procedures like hip replacements put patients at very high risk for blood clots, and so we'll see them being very strict about giving heparin to these patients. If a patient has a known clot, like a DVT or a PE, then heparin is dosed at a higher level, usually something like an 80 unit per kilogram bolus followed by an infusion at 18 units per kilogram per hour. Again, if you're following PTT, you titrate it to a level of about 1.5 to 2.5 times the normal level, checking it every 6 hours. Nowadays, we're checking anti-factor Xa assays, titrating to a level of about 0.3 to 0.7 IU per milliliter. The most common side effect of heparin is bleeding, so that would be hemorrhage and hematoma formation. Patients can develop an allergic reaction because heparin is derived from animal tissues. Other side effects we want to be aware of include heparin-induced thrombocytopenia and thrombosis, commonly called HIT. There are actually two different types of HIT. HIT type 1 is the non-immune type, and you could just call this a heparin-associated thrombocytopenia. This occurs because heparin leads to enhanced platelet aggregation and clumping, and it occurs frequently in more than 10% of patients who are exposed to heparin. And typically it arises about 2 to 3 days after their first heparin exposure. While platelet counts will decrease, it usually still remains above 100,000 and doesn't usually lead to clinical bleeding or thrombosis. It's more of something that you'll see on the lab values. Usually there's no treatment for this kind of heparin-induced thrombocytopenia. And often the platelet count will gradually rise again even if you continue giving heparin. However, the type of HIT you may hear discussed is usually HIT type 2, which is the immune-mediated heparin-induced thrombocytopenia. In this case, the heparin seems to be interacting with PF4, platelet factor 4, and leads to formation of antibodies that activate the platelets. This can occur up to about 5% of patients who are exposed to heparin, usually anywhere from 4 to 20 days after their heparin exposure, so it doesn't happen right away. Although if the antibodies are present from a previous exposure, then HIT can occur within hours. In type 2, the platelet count will drop quite a bit, below 100,000, although usually above 10 to 20,000, and we'll see an effect on the PT and the PTT levels. Patients not only have bleeding, but they can also have clotting events, and thrombotic events occur in anywhere between 30 to 80% of patients, with increased risk of myocardial infarction, DIC, DVT, PE, and necrosis. The mortality in patients who truly develop HIT type 2 is up to 30%. In these patients, the heparin must be stopped immediately, and an alternative anticoagulant should be started, usually something like lepirudin, bivalirudin, or argatroban. Heparin is reversed with a drug called protamine, which is derived from salmon sperm. Protamine is a base that combines with the negatively charged heparin, which is an acid, to form a complex that inactivates the heparin. The dose of protamine is 1 milligram of protamine per 100 units of heparin that you believe to be in the circulation. Now, protamine itself does not cause clotting. It just inactivates heparin. And in fact, if you give protamine without any heparin on board, you can actually have an anticoagulant effect that occurs from the protamine. So protamine should not be given unless you feel that there's heparin that needs to be reversed. The side effects of protamine include hypotension, pulmonary hypertension, and allergic reaction. Remember that the P in NPH insulin stands for protamine, and patients who have had NPH insulin in the past may become sensitized to the protamine and then have an allergic reaction the first time they're exposed to protamine. We said that protamine allergy is a common, or not a common, but a concern that you need to be aware of. And patients who are at risk for protamine allergy, including the diabetic patients that we just discussed, are patients who have fish allergy and also patients who've had a vasectomy. Now, the data to support this is really limited to case reports, and many patients who have fish allergies and who have had vasectomies have received protamine without any allergic reaction. Nevertheless, the textbooks do describe these as concerns to be aware of. Can patients who are allergic to can patients who have a shellfish allergy get protamine? It seems that there's no concern for these patients. Shellfish allergy is not the same as fish allergy. And once again, a reminder that NPH insulin contains protamine. So we've talked about unfractionated heparin and its reversal agent protamine. Please contact me if you have any questions about this topic, and we'll continue in the next video.